Very good morning to all. My topic is techniques of pan-retinal and scatter photocoagulation. So just brushing up on the indications of pan-retinal laser. First is proliferative diabetic retinopathy, neovascularization secondary to CRVO, retinopathy of prematurity, Coats disease and Eales disease, as sir was talking, the incidence has come down now, familial exudative vitreoretinopathy or ocular ischemic syndrome. So just brushing up on how does PRP works. Once you give the laser burns, it causes vessel shrinkage, and the retinal burns itself destroy locally the retinal tissue, which leads to reduced oxygen demand and further reduction in VEGF. The VEGF levels decreases. So ultimately the complications from VEGF, that is vitreous hemorrhage and neovascularization, they also decrease. So as discussed by previous speakers, there are two modes of laser delivery. One is slit lamp, which is ergonomically better both for the patient and for the doctor. And one is LIO for the more peripheral lesions. So as previously the speakers were discussing, there are two types of laser. One is single spot and one is multi-spot, that is Pascal. Single spot laser can be done when you have maybe a lower patient load or when you have one or two patients. So that takes slightly more time. The Pascal laser, you are able to give up to 16 or multiples of 4 spots. So you can do the same patient in 1/3 of the time. And they're more, these Pascal lesions are more well spaced. I'll show you them in the further slides. So a technique for doing a laser is we put topical drops, put a coupling agent in the form of either a visco or like any gel. You adjust the magnification brightness and set the laser parameters. I'll show you the laser parameters now. So these are the common laser parameters. The power is mostly from 200 to 800 milliwatt, depending on the media clarity, depending on the patient's lens status, if he has a cataract or if he's pseudophakic or clear lens. Spot size is usually kept to 200 to 500 microns. Exposure time is here it is in 20 milliseconds. It is actually 100 to like 50 to 100 or 200 milliseconds. So this is the most common lens which we use to do, which we use in PRP laser. It has a magnification of 0.51 and it gives a very good field of 165 degrees. So you are able to see almost most of the retina in real time. So you can manage your laser delivery better. So these are other two PRP lenses which are less commonly used, but most common use is this Mainstar PRP. So this would be the most important slide. Here, as we can see, the first usually PRP is completed in 3 sittings. So the first sitting should be done in the inferior most part of the retina. Reason being, if anything bleeds from a neovascularization vessel, with gravity it will settle down. So it will not hinder you from doing further PRP sittings, which is superiorly or nasally or temporally. Second sitting you can either do on the nasal and temporal sides and superiorly. So I was talking about the Pascal laser, the pattern scanning laser. So this is basically a semi-automatic pattern laser, because here you can control where to do, and the laser points are also well spaced. So I'll show you one. So this is LIO, as we discussed, for the more peripheral lesions. So I will show you one small video. This is basically a laser simulator which is available on the website of American Ophthalmological Society. So I pre-recorded a video. I hope the voiceover is there. One second. How to start either a pattern. Can you increase the volume? Or a single spot laser. Can you increase the volume? First of all, we'll decide the parameters. The power which you should start the laser should be approximately 200. We need the minimum power, which gives you a gray spot. Also check the status of the laser, if it is ready or it's on standby. You should put the status to ready. Spot diameter is 200 microns.
Exposure time can be 10 seconds or 20
Exposure time
milliseconds,
is approximately
depending on whether you are
100
able
millisecond.
to achieve
So
that perfect
this is
gray
one
color.
correction which needs to be made
It
here.
should not be too white and should not be too faint.
One method.
Single spot laser, as we have decided, here the power is not sufficient, so we'll increase the power.
Basically, we need dirty white gray burns.
So
These are the
spots are
adequate
more
burns.
clear
We
to
don't
you,
need
so
very
increase the
intense
power.
burns.
Dirty white.
I mean
ये तो
gray.
off white ठीक है.
Gray color burns.
So you can see the single spots which are coming. In PRP, for a diabetic retinopathy, we initially start with the inferior retina. So I'm shifting to pattern scanning laser now. So this is the pattern which we have decided. So the spot size is 200 microns, exposure time is 20 millisecond.
So basically, you need
So
to
in
stay
pattern
clear of
scanning,
the
you
major
can
blood
give
vessels
more equidistant and well spaced laser
and start with
marks.
the inferior retina in the first sitting.
So once the inferior retina is complete in the second sitting,
Second sitting can be done either nasally, temporally, or superiorly.
Try to leave the area inside the arcade not exposed to laser. So in the second sitting, once temporal and nasal area is completed,
Ideally, we should stay away
go to
from
the superior
major
retina.
blood vessels and 2 disc diameter away from the optic disc as well.
You can see the pattern scanning laser.
So
saves you
Pascal
time,
laser will save you
gives more
time if
equidistant
your workload
spots
is more.
as compared to the single spot laser.
That's it.